Welcome everybody to the Aspire Digital. Tonight's session is going to be on infra-inguinal intervention and in a format of a how I do it type session. We've got some fantastic speakers tonight. First up tonight is going to be Murray Flett, who's going to talk about Femoro-popliteal intervention. And then we've got three other panelists tonight. We've got Ash Patel from King's College London and Guys Promises. He's going to do a little bit about SFA recanalization along with lithotripsy. And then we've got Craig Nesbitt from the Freeman Hospital in Newcastle, and he's going to talk to us about atherectomy. And then Lorenzo Petrone is going to talk to us about some below the knee intervention. So I think we'll get cracking. Murray Flett's first up, so I'll hand it over to Murray. Just as Murray's getting set up there, just a quick reminder that to post your questions in the Q&A section, and we'll try and pause and answer those as we go. Don't feel shy about putting questions. There's no silly questions tonight. We're all here to answer those. Okay.
Yeah, I am going to talk about infra-inguinal intervention. Right. Here we go. Just an overview, really. I'm going to talk a little bit about the background to the problem, as well as essentially how I practice, or how we practice in my hospital. Patient selection and case planning, how I do it, and focus mainly on femoro-popliteal intervention. A couple of the other speakers after me are going to talk more about infra-popliteal below the knee intervention, as well as some newer techniques. I'm going to mention some tips and tricks for dealing with difficult cases, a brief discussion of the evidence base such as it is. I was going to talk about setting up a service, but I think I might leave that to a discussion at the end amongst the panel, if that's okay. So long since I set up my service that I'm probably some younger people are better placed to discuss that. And I've made too many mistakes to be any sort of, to be worth listening to in terms of how to set up a service, I think. So just to set a bit of the background in terms of UK practice, according to HES data, the last year, 2019 to 2020, there's just over 3,000 infra-inguinal bypasses in England, 13,500 femoro-popliteal angioplasties and stents. And out of that, the vast majority were angioplasty, and there's only about 2,600 involved placement of a stent. If you look at the National Vascular Registry annual report from 2018, it looked at 3 years worth of practice from 2015 to 2017, 14,500 femoro-popliteal procedures. These are endovascular procedures, and just under 5,000 tibial and pedal procedures. High technical success rate, 88% and 84% respectively. In-hospital mortality was low, 1.5% overall. Very low for elective procedures, a bit higher, almost 5% for emergency procedures. It should be noted that the case ascertainment in the NVR is extremely low, 21% estimated in 2015 and 33% in 2017. So we need to be submitting more of these cases into the NVR. So in terms of patient selection, this really is how we practice my hospital. And I think this kind of reflects UK practice in general. So we assess the patients clinically in terms of the severity of their symptoms, the severity of their limb threat, their comorbidities, the risk factors, and life expectancy, as well as the anatomical extent of their arterial disease. And we still do quite a lot of femoro-popliteal bypasses and femdistal bypasses in patients who are fit with a reasonable life expectancy, who've got long saphenous vein available. But we do take an endovascular first approach if they are unfit, have limited life expectancy, and there's no autogenous long saphenous vein. We would take an endovascular approach rather than go for a prosthetic bypass. It's interesting, just if you see what is defined as a long lesion in the recently published Global Vascular Guideline on Chronic Limb-Threatening Ischemia, they define glass stage 3 as SFA occlusions of greater than 20 centimeters or more, including popliteal disease or popliteal CTOs. And that's roughly equivalent to task type D lesions with SFA CTOs of 20 centimeters or more. And for those procedures, they're recommending the global vascular guideline on critical limb-threatening ischemia recommends bypass first in standard risk patients with autogenous vein available. This is the GLASS staging system, global limb anatomic staging system. I think this is taking over from the previous task 2 classifications. Very complex, difficult to remember, but this is just a descriptive simplification of it, if you like. It's divided into stage 1 to 3, depending on the length of disease and the involvement of the popliteal and crural segment. And it's based on what they anticipate would be this technical success rate of these procedures, as well as 1-year limb-based patency. So in our hospital, our case planning is key. We think everyone gets a duplex ultrasound. Most people get a CT angiogram. We don't have access to MR angiography in the time frame that is necessary for treating patients with critical limb ischemia. I should have said focus mainly on critical limb ischemia, because that, or chronic limb-threatening ischemia as we're supposed to call it now, because that is the bulk of our practice. We don't get CT angiography in everyone. We sometimes proceed directly to catheter angiography after duplex if there's no evidence of aortoiliac or common femoral disease, and if there's heavy calcification that we think will make CT angiography difficult to interpret, particularly in the tibial vessels. And if there's a duplex lesion suggestive that is amenable to endovascular treatment, then we'll go ahead directly with a catheter angiogram. Most of our procedures are done in interventional radiology under local anesthetic. We do not have a hybrid vascular theater, but we do have fairly high-end mobile C-arm, so-called hybrid edition. It's a flat panel C-arm, and it's absolutely adequate for doing peripheral procedures. Might be a bit more limited for aortic procedures, but there's absolutely zero issues with it. In terms of the radiation skin dose that is recorded, it's very similar to the fixed imaging in the interventional radiology department. But you also have to think about radiation protection in your theater. We have all that in our theater. The only thing we don't have is fixed imaging in terms of a proper hybrid theater. Most of our procedures are done under local, but a lot of patients are tolerated poorly, particularly those patients with rest pain, lying flat, and getting contrast boluses injected is associated with a great deal of pain. So we're doing more and more procedures with regional anesthetic, sciatic and femoral nerve blocks. Sciatic for analgesia and femoral nerve block to keep the legs still. And we find when we do that a lot of these patients just lie content and snoozing for however long you want to take to treat their disease, unlike those patients under local anesthetic who often tolerate it very poorly. Some patients get done under general. It's a mix of patients being done in IR and some in theatre, particularly the hybrid cases are done in theatre, but also some of the percutaneous cases that in patients who require some form of anesthetic support. We give 5,000 units of heparin to everyone, use a lot of GTN to counteract vasospasm, which can be a problem, particularly if you're treating distal disease in the leg. So my approach to treating infra-inguinal disease, either an antegrade ipsilateral common femoral puncture, use a micropuncture kit, then upsize that to a 4 French sheath initially. If a stent's going to be placed, then may have to increase that to a 6 French. Occasionally we often have to use the retrograde contralateral approach up and over the aortic bifurcation. Antegrade approach can be difficult in obese patients, limited by inflow disease, obviously, and SFA origin disease. And a retrograde approach can be much easier in obese patients with proximal disease. We do lose some pushability and torque control, particularly if there's an acute or calcified aortic bifurcation. So this is just an image of a patient that would be ideal for an antegrade puncture, patent common femoral artery and bifurcation, proximal SFA is patent, but there's a distal SFA popliteal occlusion. Unless there was morbid obesity, you wouldn't choose to treat that from a contralateral approach. On the other hand, in this patient, there's just a nubbin of SFA at the origin. That'd be quite a challenge to have stable access going antegrade from an ipsilateral puncture. So often go from the other side, cross over the aortic bifurcation, park a sheath in the common femoral artery, and then go down from there. I don't know if you can see that, or if the people's faces are in the way, but that just then gives you the pushability with the sheath in the common femoral bifurcation to start crossing that lesion. These kind of sheaths make that much easier. These are not standard bright tip sheaths, which are made of nylon, which will kink in an aortic bifurcation. These sheaths are got hydrophilic coating. They're supported with the stainless steel coils and extremely flexible dilator. So they're absolutely ideal for crossing the aortic bifurcation, particularly if it's calcified or acute. And so my go-to sheath, I would say. The other one, which is similar but not as flexible, is the Terumo destination sheath. We also use retrograde popliteal access, flush SFA occlusions, which can be difficult to get into from an antegrade approach. Also, if you had a failure of antegrade recanalization, or if you're using a Safari technique to cross an SFA. This is a patient who's prone with a popliteal, a 4 French sheath in the popliteal artery. And I must admit, I've kind of moved away from doing that and I actually prefer to treat patients supine. And if I think there's a likelihood that we will need retrograde access, I will prep the patient like I would be doing for a bypass. So it won't just be a small area of skin prep in the groin. I'll prep the entire leg so that we can get retrograde access into the popliteal should that be necessary. It's quite challenging. It's quite easy getting into the popliteal with a patient prone. It's quite a challenge from the medial approach. Certainly I find it challenging, not mainly because I don't do that many of them, but it's certainly feasible. And although it takes a bit of time, I've not failed to get access into it, but it is a challenge. Well, I find it a challenge. Retrograde tibial or pedal access don't really use much at all, or hardly ever, for femoro-popliteal treatment, but they are. It is feasible, and it's more used for tibial intervention or tibial and femoro-popliteal disease rather than fempop disease. So, my approach to treating, straightforward focal. Superficial femoral artery disease, antegrade common femoral puncture, short 4 French sheath. With this kind of disease, you can pretty much use any angled tip or a straight catheter of choice. Don't think it really matters. I tend to use a 4 French catheter and 035 guide wire, usually Terumo glide wire. Occasionally, I'll use a V18 wire. If you cross these lesions with an 035 guide wire, to deliver a low-profile balloon, you will then have to exchange for a V18 for an 018 guide wire, because most low-profile balloons are on an 018 platform. So, if it's a straightforward lesion, you can use a 4 French catheter with a 018 guide wire, if you wish. Transluminal for most of these types of lesions. And you can plan, if you've got a CT angiogram, you can size your balloon according to the diameter of the native vessel, but typically SFA is 5 or 6 millimeters, popliteal 4 to 5 millimeters. Don't forget to always check the runoff after you've treated the SFA. So more complex disease. Metastatic C and D lesions, glass stage 3 lesions. This is the go-to catheter that I would use, a dedicated support catheter, if you like. This is a Cook CXI catheter, and it is utterly invaluable, I think, for crossing long CTOs in the infra-inguinal segment. So these come in 2.3 or 2.6 or 4 French sizes. They're all the distal 20 or so, or the 30 centimeters of the catheter is hydrophilic. Throughout its entire length, it's got a stainless steel braid. I don't know if you can see that. And these are not selective catheters. They don't come in different shapes. but you can get them straight or angled tips. And they are just invaluable for crossing CTOs in particular, but probably a bit of overkill for short occlusions or stenotic disease. Guide wires, my go-to catheter and guide wire for the SFA and popliteal is usually a 4 French catheter, CXI typically, with an 035 Terumo glide wire with an angled tip. And it's, I would regard it as being the workhorse in the SFA, steerable, one-to-one torque, hydrophilic, and excellent for crossing SFA lesions, I think. CTO wires, these are high tip load wires that can be useful for crossing calcified chronic total occlusions, but use them less often in the femoro-popliteal segment compared with below the knee. This is just the anatomy of the Terumo glide wire. There are other wires on the market which are very similar, but this is the one that we have. It's got a hydrophilic coating, it's radial opaque, it's got a one-to-one torque. Typically it's angled tip, you can get them straight. I don't really see the point of having a steerable wire that's straight, I must admit, so I almost always use the angled tip. And they come in 035 and 018 diameters and standard or stiff shafts. So that's by far the wire that I use most often in the FemPop segment. Other wires, V18, V14, that's an 018 and 014 wire from Boston Scientific. Use the V18 particularly if at such times when you want to stay luminal rather than subintimal in the FemPop segment. But the 014 wires, like the command wire, the Abbott command wire is an 014 wire that you use below the knee, and it would be my go-to wire. It's a stainless steel wire with a long hydrophilic nitinol taper on the end of it, which is absolutely excellent in below the knee segment. And we also have CTO wires, which, as I said, are these weighted tip wires, stainless steel with I think it's a tungsten tip, and the different gram weightings refers to the force on the tip of the wire before it deflects. So they are good for punching through hard caps to atherosclerotic plaques. Not good for going through tortuous anatomy. They should only be advanced a few millimeters ahead of the catheter. So, you know, if you just ram that down a vessel, particularly if it's tortuous, or then there's a risk of perforating with it. But very good for short distances and straight vessels. So, crossing the lesions, there's different techniques. There's transluminal, subintimal, with or without the help of a re-entry catheter to get entry into the lumen distal to the lesion. There's also the Safari technique. And it's a question of, you know, what technique you use and when, and often the nature of the lesion actually dictates how you cross it, because, you know, sometimes long lesions you can only really cross them in the subintimal plane. On the other hand, sometimes, particularly with calcified CTO, it's only possible to do it luminally. And in terms of evidence for the benefit of one technique over the other, there is no evidence really at all. And I think it's based on your experience, your preference, and just how it's possible to cross any given lesion. Like, for example, this short popliteal lesion, maybe a 1 or 2 centimeters, you'd imagine it would be very easy to cross that luminally. But in fact, I don't know if you can see in this native image, there's just a very hard lump of calcium. So this particular lesion required a long 4 French sheath to support a catheter, a dedicated support catheter with, and a subintimal crossing of that lesion with a massive amount of force exerted to get across it. So you sometimes can't really tell just by the length of the lesion itself. You know, this is a heavily calcified lesion and required a subintimal technique with a great deal of support. So subintimal angioplasty, there's no great technique to initiating a subintimal dissection, I don't think. You use an angled in this particular case, there's an SFA origin occlusion. It's not flush occlusion. There's a little stump at the SFA. Use an angled catheter to direct towards the wall of the artery. But essentially, if you push a hydrophilic wire like a Terumo, it will start to distort, and before you know it, it'll be dissecting a subintimal plane. That's what it will do, and it's almost an effort to prevent it doing that should you wish. So initiating a subintimal dissection is very straightforward. Typically, the wire will then start to loop in the subintimal plane. It's quite important not to advance the wire loop too far ahead of the catheter, because it will get wider and wider as you advance it beyond the catheter, with a risk of perforating the artery. So you should always follow it reasonably closely with the catheter. That particularly applies if you're using a stiff hydrophilic wire. You've got a higher chance of perforating, particularly if you allow that loop to get too wide by advancing it ahead of the catheter. Get re-entry. I think it's very important to have a limit on where you think you should get a re-entry into the artery, and not keep on progressing more and more distally, potentially ruining the option of a future bypass by dissecting down indiscriminately. I think if a patient has an option for a bypass, you should have a limit on where you're going to get re-entry into the artery, and not progress indiscriminately beyond that. Or I think you will potentially compromise the future possibility of doing a bypass. So, what are the limitations of subintimal angioplasty? I think, like I've just said, establishing a subintimal dissection is not difficult at all. Almost happens by itself, just by pushing. But re-entry into the lumen distal to the lesion is probably the rate-limiting step. And it's the one thing that we have different tips and tricks and devices for dealing with is getting re-entry. Calcification is a limitation also. It can be very difficult to get re-entry into a calcified vessel distal to the lesion. I'm just going to show you an example of my standard sort of practice for attempting re-entry. This is a patient with a long lesion from the occlusion from the SFA origin, reconstitution of the popliteal artery just above the knee, and decent runoff. Now, this kind of patient, we, as I said before, we would treat this patient with a bypass if they were fit, had a long saphenous vein, reasonable life expectancy, et cetera, et cetera. So this type of patient we're treating with an endovascular approach because there's one of these or all of these things are missing. So just, because there's no doubt in my mind, and I think the evidence supports it, such as it is, that someone with a reasonable life expectancy, that a vein bypass is a far more durable option than treating this endovascularly. Anyway, having said that, these kinds of lesions often will be crossing subintimally with a long wire loop. And looking at that previous angiogram, you were aiming to get into the popliteal artery just above the knee. And whereas here we've got quite a long loop of artery, there's no way that that will ever go back into the lumen, that long loop. If you keep pushing that down, you'll dissect right down into the tibials. So you have to shorten the loop and get re-entry. I just showed a magged up picture of that. So you're not getting rid of the loop altogether. It's a very short loop, and effectively just twiddling that around hopefully in relatively disease-free artery distal to the occlusion. And if you're going to get re-entry, that is the way it will happen immediately if you're going to get it. There are other things you can do if that doesn't happen immediately, but quite often that will get you back into the lumen immediately with that short loop. I can't remember who it was that gave me that tip. It was a long time ago, but it's been one of the most useful tips that I've ever had, I think. And then, having had re-entry, always check that you're in the lumen before you treat the lesion. This patient's been treated with a plain balloon angioplasty, long length of disease with a good-looking result. We can talk a bit later about how we treat these, whether we treat them with plain balloons or stenting or other modalities, but just focusing on the crossing these lesions. So this patient has a flush occlusion at the origin of the SFA. It can be impossible to get into that at times from an antegrade approach. So this patient's turned prone and with a popliteal puncture. And again, we've got a subintimal wire up into the common femoral. But on this occasion, there's unable to re-enter using standard techniques. So this is one of the devices that we can use to help us. It's a re-entry catheter called the Outback, and it's effectively got a curved, sharp cannula that you can advance to puncture into the true lumen of the artery, and then advance the guide wire up into the lumen. And that it is a very effective device. It costs about £1,000, I think, but it is very effective. I found it far less effective going down. The smaller the artery you go down distally into, the less effective it is. But going retrogradely, particularly in the iliac segment, it pretty much always works. Balloon lesion. In this particular case, you can see there is an issue with a dissection flap just in the common femoral artery, which is clearly where the re-entry took place in the common femoral, because there was a flush occlusion. And that actually caused a problem in this particular patient. It required, subsequently, it needed a femoral end atherectomy and a patch to deal with that. And I think these flush occlusions, I do not think they're best treated by percutaneous endovascular techniques. I think they should have a hybrid approach with an endarterectomy and a patch and a distal recanalization. But I think a purely percutaneous approach for these flush occlusions is a problem, because there's a risk of stenting across the profunda origin, or in this particular case, we've got this re-entry dissection flap in the common femoral that was a problem. So another example of a failure of re-entry, another patient with a proximal superficial femoral artery occlusion, reconstitution of the popliteal artery above the knee, 2 vessel runoff with a high takeoff of the posterior tibial and the anterior tibial. This patient, again, can't remember if there's a ipsilateral antegrade approach or contralateral up and over, but dissecting down in the subintimal plane. Often that's the only way to cross these lesions, as I said, but unable to break back into the lumen of the popliteal artery. So in this case, we've chosen to do a retrograde popliteal puncture. And this is much easier if you've already prepped the patient in anticipation that this might be necessary. So if I think there's a possibility of that, then this is how I prep the patient. So we don't have to re-prep them, turn them prone, turn them back, supine. It can all be done without having to rearrange everything. So you've got an antegrade wire that's obviously punctured the artery in the luminal puncture, but is dissecting down in the subintimal plane without re-entry distally. You've got a retrograde wire coming in the subintimal plane. And as often as not, these 2 wires are in the exact same subintimal plane, so it's possible to snare the wire and retrieve it through either the antegrade or retrograde sheath. And thereby you've got a through and through wire, and that facilitates the antegrade passage of a catheter getting down into the lumen distally beyond the occlusion. I actually prefer this to using Outback catheter in the distal SFA or popliteal artery. And then typically you take the sheath out from the popliteal puncture and just inflate a balloon for 3 or 4 minutes for hemostasis at the puncture site, and treat the SFA occlusion with a reasonable result. And I can't remember if this patient was primary balloon or plain balloon angioplasty, we stented the patient, but as I say, we'll discuss that in a minute or two. Case 2, briefly, it's a case you might not think there'd be an issue with. Relatively short distal popliteal distal SFA proximal popliteal occlusion. Reconstitution, however, of quite a diffusely diseased popliteal artery with a single runoff vessel, the anterior tibial. So again, the only way that work could be advanced with subintimal and could not get back into this diseased popliteal. So retrograde puncture of that disease popliteal on ultrasound, it was very thick-walled and diseased. However, the anterior tibia in the calf was relatively disease-free. So it's actually it's feasible, although it hardly ever used tibial or pedal access for the FemPot segment. It is feasible to puncture. I've only ever used the anterior tibial, but it's feasible. And then a safari technique in the same way as the previous case. Now I have to say that this patient, we were treating critical limb ischemia in a patient with metastatic disease. This kind of popliteal CTO wouldn't be first choice for endovascular treatment, but in a patient with a metastatic disease and limited life expectancy, it was part of his palliative care really to treat his intractable rest pain. You should notice that when we've punctured the anterior tibial, everything is gone. That's a relatively normal vessel, but it's gone into really severe spasm. So we give a lot of GT in this situation for that spasm. On this occasion, the wire went retrogradely in the lumen, and it just sailed straight into the antegrade sheath. So a rendezvous with antegrade sheath, and it, again, establish a through and through wire. So we could get a catheter antegradely and then balloon the diseased segment, tamponading the anterior tibial puncture site, then treating the popliteal and the SFA. Just to say that a safari technique, I think all but on one occasion, the two wires, the cases, a relatively small number of cases has to be said, but the wires have been in the same subintimal plane except for one case when the antegrade and retrograde subintimal wires, but in a different plane and just could not join the two. But in this situation, if you inflate a balloon in one of the, either in the antegrade or retrograde wire, in that plane, if you inflate a balloon and use an outback catheter, you can puncture the cannula of the outback catheter into the balloon and thereby getting into the same plane and establishing the same through and through wire. I've only ever done that once. It's feasible. In terms of when do we use a luminal approach rather than a subintimal approach? And it's usually dictated by the patient's lesion. In this particular case, we had a SFA origin occlusion, and we treated that from a contralateral approach, cross over the aortic bifurcation, and the only way of advancing a wire was transluminally. And that can be a very difficult thing. I find it very difficult to advance a wire through a long occlusion transluminally, and it requires a great deal of support. A long sheath, a 4 French catheter, then a 2.3 French catheter coaxially through that, and using a variety of 014 wires just to gradually punch your way through that lesion. But the reason that was done is because you simply couldn't cross it in the subintimal plane. There's a sheath up here in the groin. This is the tip of a 4 French catheter, and then there's a 2.3 French catheter through that, advancing slowly in luminal plane. It looks like a dog's dinner when you balloon it typically, and it mandates stenting the full length of the lesion. So there are a variety of techniques for crossing SFA and popliteal CTOs. Subintimal technique with or without a re-entry device for a safari technique. And transluminal, I find a lot more time intensive, it's a lot harder. It requires specific catheters and wires, and there are some dedicated crossing devices. The only experience I have of using one is the TruePath from Boston Scientific, which is essentially a diamond tip rotating drill, which drills through CTOs. Which one's better? There are no RCTs comparing transluminal angioplasty with subintimal. Subintimal angioplasty has been shown to be safe, with probably with higher technical success than intraluminal angioplasty, and comparable midterm patencies. But there is no direct comparative trials comparing the two. I suspect there never will be, because the nature of the lesion dictates how you cross it, really, and it's a question of crossing it however you can. That's what I think, at least. Yep. So in terms of stenting or not, in the infra-inguinal segment, we use nitinol self-expanding stents. I think stainless steel balloon expandable stents have been shown in the past not to be effective and unsuitable for infra-inguinal disease. And these are nitinol stents which are cut from a laser cut from a tube of nitinol, and they're essentially unsheathed and they expand within the artery. They should be oversized, typically by 1 millimeter or so that you get decent wall apposition. There are different kinds of nitinol stents. The superior stent is an interwoven nitinol wire stent, has high radial force and great flexibility, and I think is the only currently available stent that's licensed for use in the popliteal artery down to P2 to the knee joint level. The Go or Tiger stent's no longer available. I think it's been withdrawn. And there's a variety of other modalities that we can use, including drug-coated balloons, drug-eluting stents. We mentioned the Supera interwoven nitinol stent and the Viaband covered nitinol stent. In our practice, we typically use plain balloon angioplasty with bailout stenting, and that is probably quite old-fashioned practice. But maybe just discuss the evidence for and against using different modalities. So I think this systematic review was done as part of the recently written global vascular guideline on critical limb-threatening ischemia, and actually found that there were no studies in their meta-analysis that they found whatsoever looking at stenting in Femoro-popliteal disease in patients with critical limb ischemia. There is a vast number of studies, but the overwhelming majority of patients in all of them are claudicants. So there's really no information, I don't think, on the benefits in patients with critical limb-threatening ischemia on using stents, routine placement of stents in the femoro-popliteal segment in terms of improving amputation-free survival. There are a lot of trials looking at plain bare metal nitinol stents, looking at drug-coated balloons, looking at drug-eluting stents, and covered stents, the Viaband, as well as the Supera interwoven nitinol stent. And all of these trials show benefit in terms of radiological endpoints, target lesion revascularization and primary patency in groups of patients that are overwhelmingly have claudication rather than critical limb ischemia. So they do show a great, a significant benefit in terms of patency compared with plain balloon angioplasty, but really little evidence of benefit in critical limb ischemia. And also there are now 2 meta-analyses of all the paclitaxel trials suggesting that there's an excess mortality associated with their use. The first one, December 2018, looked at trial level data in patients, showed an excess in all-cause mortality at 5 years. And just in June this year, May or June this year, there's a further meta-analysis that actually looked at individual patient data. Total of over 2,000 patients, median follow-up was 4 years. And there was, again, an increase in all-cause mortality at 4 years, 38% relative increase and a 4.6% absolute increase. But it should be noted that there was quite a significant loss to follow-up in both groups, 24%, 23%. And when they included these patients lost to follow-up, there were still that significant excess mortality risk, but less so than in the initial analysis. And so the MRHA has issued a medical device alert a year or so ago that the paclitaxel devices should not be used in claudicants because of the potential mortality risk, although it suggests it could still be used in patients with critical limb ischemia. Certainly in my hospital, we don't use them at all now anymore. And I think I'm not sure, that probably varies quite a lot throughout the UK. In terms of upcoming evidence for femoro-popliteal disease, There's Basel 2, which is essentially the same trial as the original Basel trial, but it's in the infra-popliteal segment. And there's Basel 3, which is a 3-arm trial comparing different endovascular modalities. Plain balloon angioplasty with bare metal stenting as a bailout versus drug-coated balloons, again with bare metal stenting as a bailout versus drug-eluting stents. And the primary outcome of both trials is amputation-free survival. Both of these trials, I think, were suspended in the wake of the meta-analyses that came out, and also due to COVID potentially, but I think they're both now recruiting again. Where they are in terms of recruitment target, I don't know. And the other trial from North America is the BEST CLI trial, which is comparing surgery first approach with endovascular first approach in patients with infra-inguinal disease and critical limb ischemia. I think that trial has stopped recruiting. We're just awaiting results to be published. So that is all I have to say. Thank you very much. And happy to take any questions.
Thanks very much, Mary. That's a really comprehensive overview there of infra-inguinal treatments. Sorry, there's a couple of questions just cropped up on the Q&A as we've been going, and I'll put those out to the panel as well as yourself. The first was an interesting question. Someone in the audience asked, with a short SFA occlusion, maybe 5 to 10 centimeters in a critical ischemia, rest pain patient, and a single vessel runoff, would you still consider endovascular treatment first, or would you be worried about distal embolization?
Well, if I can answer that, I think yes, I would. I don't. The risk of distal embolization is no higher, but the consequences clearly are potentially worse should that happen. But you know, careful counselling of the patient. I think a 5 to 10 centimeter lesion, you know, is that would be an endovascular first approach for us.
Yeah, absolutely. I think I'd do the same, and I think I saw Lorenzo typing the answer as well, saying that he would not hesitate to treat that. Ash, Craig, what do you think?
Yeah, I agree. I wouldn't hesitate to go endovascular in that sort of lesion. And as Murray said, the risk of embolization is the same anyway. And there are adjuncts if the patient does embolize, you know, if you need to do some aspirations, thrombectomy. So it's quite rare.
Just moving on to another question. It was just about subintimal angioplasty and dual antiplatelets. Do the panel, what does the panel do with subintimal, long subintimal angioplasties? Do you routinely use dual antiplatelets, or is it something you just use selectively?
I think James, I answered that one on, didn't I? I think Murray are still using DCB, so we'll always use dual antiplatelets in that setting. I think to say never in subintimal and plain balloons is untrue. I think you've got a big long lesion, you will sometimes get a feel for some that are more likely to thrombose, but in general terms, just stick with a single antiplatelet agent unless we're using drug-coated balloons.
Lorenzo, what's your thoughts on that?
I think, yeah, as you said, you know, it's a dual antiplatelet therapy. It's very good for any of our patients. Actually, we're now switching to rivaroxaban plus single antiplatelet. But I think if we're not aggressive with our antiplatelet or our anticoagulant, then, you know, especially these long dissections are gonna come down. Actually, sometimes I'm pretty aggressive with stenting, especially with patients with CLI, right, for 5 and 6. For long SFA recanalization. And I think also there's a lot to talk about, but also the IVUS can give you a good understanding of the flap and how the long dissection could be stented also with spot stenting. So I mean, it's be an hour discussion if you want to do it.
And Ash, what about you?
Yeah, I would generally always use dual antiplatelets, and that's what we do as a unit. More recently, the COMPASS study has sort of muddied the waters a bit because rivaroxaban and aspirin, based on that study, would be beneficial long term. So we have started moving towards that, but then adding on clopidogrel in patients who get DCBs. But then obviously you're increasing the bleeding risk. But traditionally, we've been dual antiplatelets.
Is that for 3 months, Ash, or do you keep that on long term?
So it'll be 6 months, and then we switch to a single after that.
there was a question earlier on about Safari complications. Someone just asked, what are the potential complications of Safari technique? Murray, do you want to answer that one?
Yeah, I've not had any specific, complications specific to the Safari technique, I must admit. I mean, I have emphasized that it is something I would say I started doing in the last sort of 12 months or so. Rather, we would previously, if we'd failed with an antegrade recanalization, we would previously send a patient back to the ward and bring them back a day or two later, prone for a retrograde attempt. But I've just I think it makes far more sense to do it with the patient supine and treat them at the time. You can usually have an idea when you look at an angio, if that is going to be required or if it's likely to be required, and set aside an appropriate length of time in your list for it. But anyway, to answer the question, I've not seen any specific complications related to Safari technique.
Can I add something about retrograde access? Actually, there are very different many techniques to puncture the artery retrograde. And I think it's to put the patient prone is absolutely outdated. We need to, as a community, we need to stress that. So there's two nice papers, one from Silvestro in 2018, another one from a Japanese group where they are puncturing the popliteal artery from the lateral side, which is very handy, works very well. I did it many times, it works very well. So you go through interosseous membrane from a lateral view. You just have to have the tube angulated to put the tibia and the fibula on, having a good window. And then this saves you the need of bringing the patient back with just retrograde approach and on a popliteal, which I think is very, it was described the first time in 1988, and I think it's not anymore valid in our practice. It shouldn't, in my opinion.
I agree, but I've been quite late in adopting that approach, has to be said.
Okay, thank you very much, panel. I think what we'll do is move on now to Ash's presentation. So over to you, Ash.
Hey, can you see my slides yet? Or?
Yeah, we can. Thank you.
Okay. So I'm going to give you a quick whiz through, although I can't actually control my slides at the moment. 1 second. Apologies. Try that again.
So just while Ash is kind of getting that technical glitch sorted out, there was another question come in there. Does anybody do surveillance post angioplasty, or is it just clinical surveillance? Does anyone do duplex or anything like that?
Not really. Yeah. Okay. Sorry, Murray. Go. You go.
No, we do. Actually, a similar sort of. If stents are placed, a similar surveillance as bypass grafts have. For angioplasties alone, we as clinical follow-up and ABPIs rather than duplex. I'm not quite sure if that rationale makes sense, but that's what we do. It's quite a historical thing. But I must admit, I personally believe that if you are going to be treating these kind of lesions, that it doesn't make sense just to stand by and wait for them to re-occlude. That I think re-intervention proactively is the way forward, I think.
Thanks, Murray. Looks like Ash is back up and running. So over to you.
Great. So there's two cases, but I'll fly through the first one. Essentially, Murray has said a lot of things that I would say, but here's a lady who is in her 70s, and you can see that she had progression of her CLI quite rapidly over a couple of weeks. She's frail, not got good vein, and a poor anesthetic candidate. And quite often there's a CT scan running showing really severe common femoral disease and essentially total occlusion of her SFN multi-level disease. And during COVID, we had quite a few patients presenting with sort of multi-level disease and really severe CLI needing straight line flow. And the global CLI guidelines also say if it's a small lesion, then you can go for an inflow procedure, but consider multi-level treatment in these sorts of patients and offer endovascular treatment when it's technical and they're high risk, and also consider adjuncts. And you can see how diseased her SFA is. And this goes all the way down to a foot, so I won't continue with the video. So this is a reconstruction of her CT, and you can see severe common femoral disease, severe SFA calcification, and her runoff disease is also very severe. So we did a hybrid procedure, so done a femoral endarterectomy and then punch at the other side, do a diagnostic angiogram, and you can see just above the patch. I wasn't quite happy with that. There's some calcium there, so we've gone and stented it, but that's just the start of the procedure, because the main issue was her SFA and her runoff. So the endarterectomy is very useful because you can create a nice SFA stump rather than having a flush occlusion. So at this point, as Mari mentioned, the question is, do you go subintimal or can you stay within the lumen? And this is her runoff angio, so always do a diagnostic before you start your procedure. And to cut a long story short, the wire essentially went subintimal, and you can see how where the arrows are, there's some really severe areas of calcification. And I would normally use Jetstream or an atherectomy device for this, but when you're subintimal, that's not an option. So in this situation, I did not use an outback. We broke back using a wire, and so in this situation, the next strategy is to pre-dilate the whole area, and this particular lesion is very, very calcified. But you can see there's a reasonable outcome with just simple plain balloon angioplasty. But there's no way you can leave these sort of dissections, and as Lorenzo said, you need to have quite in my practice, a very low threshold for stenting, especially in CLI. And we use Supera stents, and so the key with Supera is to pre-dilate your lesion to 0.5 millimeter greater than the stent itself. So generally 5.5 or 6.5 for the SFA. We've had bad experiences with the 4.5 millimeter Supera. So in this case, I pre-dilated with a long 5 millimeter Sterling balloon. So I'm in an 018 system here, and tried to sort of crack this lesion with a high pressure balloon. And that was sort of the bane of the case throughout. And you can see here, we're still trying to crack this lesion using a Mustang balloon, which is a non-compliant balloon. And then distally, you see there's an SFA dissection. And again, you can't just leave these. So, we're still trying to prepare this vessel, because if you don't get the vessel to the size of the superior, it will maldeploy. So it's very important to keep persisting. And here's what happens. So generally, after multiple uses of the superior, you can get really good outcomes. But despite having used it several times, I knew there was going to be a problem with this calcified lesion, and you can see how it does not look right at all. The good thing about the superior is that we found that when you scan these patients several weeks down the line, the stents actually start to align themselves quite nicely. So it's best just to carry on. So this is the final stenting, and you can see we've gone from an SFA occlusion to something that starts to look quite good. And at the top, I don't often use the superior because I'm going to be quite flush with the profunda, and there's always a risk of, if you don't deploy it perfectly, then you'll end up in your patch. So I'd often use a Zilver or something similar to be absolutely perfect on the patch. And then again, post dilate the stent, and again I'm still trying to squeeze this lesion, and it starts to look a bit better. So this is the SFA and the pop running, and you can see that on the perineal and the AT weren't perfect. So we've gone on to complete the procedure. So we treated the perineal first, and then using an 014 system, gone down the anterior tibial artery and then used the coyote balloon to treat the AT. And you can just about see a wire in the foot. And to echo Murray's views, start with a Terumo, and then I would very quickly escalate to an 018 and 014 system, and a combination of V18s, V14s, command and connect wires. And more recently, I've been using the Asahi, Gladius, and the CTO wires as well. And then finally, the imaging looks a lot better, and this was her procedure. So sort of 4 levels. The Zilver wasn't expected, but then the patch, a superior. So I didn't mention I used the Tigris for the P3 segment, and then plastering of her runoff vessels. I wanted to skip through that case because just before you hear from Craig about atherectomy, here's a case of intravascular shockwave lithotripsy. So this is a very young patient in his 50s. He's got sarcoidosis and severe calcification of essentially his whole vasculature. So here's a recon of his CT angio, and you can see, so he's got tissue loss and rest pain, and you can see how his whole SFA is a lead pipe, and the angiograms, the diagnostic angiograms from the referring center show these sort of concentric and eccentric lesions of the whole SFA. And I mean, the popliteal and tibial segments are awful. And you can see here with the diagnostics how what we were faced with before we put the patient on the table. So he went through our MDT. The options were bypass. He hasn't got great vein, but also what's your target here? You've got severely calcified vessel all the way down. And the other options put forward were atherectomy or shockwave. So shockwave, there's the above knee shockwave machine, which is an EM5, good for the SFA and POP vessels. And then there's the S4, which is used for the below knee POP vessels. And it's great for concentric calcium, but we weren't sure how it was going to react to his eccentric lesions. So here's a diagnostic angio. As Murray said, antegrade puncture. He had sedation. He was very compliant, actually. So here are the lesions. There's multiple lesions that we were faced with, and this is his tibio-peroneal segment with good sort of foot perfusion of foot runoff. So there was a good opportunity here to try to get some form of straight line flow with the aim of not having to stent a young patient. And as Lorenzo mentioned, IVUS is really useful here. So this is the IVUS of his SFA and POP, and you can see how, I mean, he's got severely calcified lesions, almost occlusive in places. So I want to show you how the shockwave performs. So with shockwave, you essentially you dilate the balloon to 4 atmospheres, and what it does is it emits ultrasound technology, and it essentially blasts the calcium away, and you have 30 emissions per cycle, and at that point the balloon will say that it's finished, and then you post dilate to 6 atmospheres, and you come down, and the advice is that you treat a segment as much as you need to in order to essentially break up the calcium. So we had to, the balloons aren't cheap at all, so we had to be careful how many times we treated each segment so as to not run out of the amount of shockwave we could offer for each segment. And you can see here, this is the proximal lesion, how eventually the SFA has responded quite nicely, the shockwave. And then sort of mid SFA, again, on the left you see the first ballooning, and the balloon hardly opens, and you can see the lesion as the balloon's opening up. And with further cycles of shockwave, the vessel starts to open and the balloon starts to mold into a sort of more a normal shape. So I shockwave the SFA, and just above up to the lesion, the occlusion. And you can see there is some benefit. I wouldn't say it's perfect, but certainly the really, really tight lesions have been treated. And there was nothing here that was more than 40%. So we carried on with the next lesion, and this is what we were faced with. So flush occlusion of the distal SFA and the target at P1. And so having passed a catheter down, the key is to try and stay intraluminal, but you don't necessarily have to do a shockwave. You can treat lesions if you're subintimal, but this is an attempt to stay within the lumen using the Halberd CTO wire. And so managed to stay within the lumen there. And again, performing shockwave of this vessel. So I'm just going to play all the videos at once, and you can see how on the left the balloon starts to respond, and then with more and more cycles, you start to get a better result. And then finally, we've post-dilated the whole segment, and you end up with a lesion pre and post, starting to look more and more like a blood vessel. So then we're faced with the lesion around the knee joint. You can just see how severe this patient's disease is. So this is it zoomed in. So there's a segment at P2, and then there's a horrible segment at P3 in the TPT. So again, this is still using the largest shockwave balloon that's designed for above the knee. And it's very hard to see on your screens, but with the IFA, you do see with repeat cycles, the balloon starts to open up to its true shape. And you can see here, so we had a long lesion to treat at P2. So we've chosen to do 3 cycles where you can see then 3 cycles below. And then this is a lesion at the TPT. And so for this, I used the S4, which is for below the knee. A smaller balloon, less cycles available, and it's shorter as well, only 4 centimeters, whereas the larger balloons are 6 centimeters. And again, post-dilated with a coyote. And how does the lesion look? Well, it doesn't look that great at all on an angiogram. IVUS made it look acceptable, but we've post-dilated it again with a Sterling, and eventually the angiogram shows a reasonable result compared with what we had at the beginning. And so this is the final picture. So this was what we had before, and this is his patient's SFA, his sort of distal pop, and his tibial sections. And he's doing better. He's out of rest pain. And my strategy now is I'm not happy with the TPT. I don't think it's going to be long lasting, and the IVUS certainly didn't show that it was a perfect result. So there's a good chance he'll come back now for atherectomy of this segment. Although at least now, because we use the jet stream, so it's not a directional atherectomy system, there'll be a good chance that we'd have a good result with atherectomy now that he's got straight line flow to his TPT, but he'll be he's now on close surveillance clinically. So that was a flyby just to save some time.
Thanks, Ash. That's really great, actually. Just a quick question before we move on, just in the interest of time. What about embolization with lithotripsy? Is that a problem? Do you use embolic protection device, or is that not an issue?
So the Disrupt PAD trials, 1, 2, and 3, I mean, I hate when studies say 0%, but the trials have said there's 0% chance of embolization. And actually, having used a lot of jet stream and other atherectomy devices, and now the shockwave more recently, you always, well, I say always, but it's really common to get embolization with atherectomy devices because they use the Archimedes principle to try and suck off the fragments. But we haven't seen any emboli with the shockwave because the theory is that it disrupts the fragment into such small pieces that any emboli are so small they'll whiz around the circulation. So no emboli so far.
That's great. Thank you very much. I think just to kind of press on and try and get the next 2 presentations done as well, we'll move on to Craig, and it's a nice segue into atherectomy. So Craig Nesbitt from Newcastle, big Sunderland fan, over to you.
So when I use atherectomy, I exclusively use a directional atherectomy device, which is the Hawk 1 atherectomy catheter, which works a little bit like an old-fashioned wood plane, siphoning off the plaque and these are just segments that you can see. I'm going to do a couple of quick cases. The first case is a diabetic chap, ex-smoker, who had had a significant history of previous intervention. In total, on top of his common femoral atherectomy, he'd had 4 previous external iliac artery angioplasties. He'd had his common femoral and his profundoplasty as well. And he came in around April with critical limb ischemia of his left foot. So we're talking at the height of the COVID pandemic. His duplex indeed showed he'd restenosed his external iliac and his profunda. And this was his angio. This is actually what's left of his external iliac, and this is in fact his profunda origin. His SFA had long since occluded. So we took this guy on for atherectomy. It's a good case for that. It's the right sort of lesions. We chose the LX device, which is the larger device with the larger nose cone. And I do filter all these cases and it's my standard practice, because all these cases are CLTI cases, to drug coat them afterwards, and you get a really nice angiographic result in these cases. We've got him out to 6 months. His 6-month duplex didn't show any significant restenosis, which is at least reassuring. I'll fly on. My second case is a lady whose biggest history was of rheumatoid, in fact. The right total knee replacement became a real bone of contention throughout her case. And she came in just before Christmas last year with really quite significant tissue loss, horrible rest pain. Lovely lady, really quite an affluent lady who'd been seeing a private podiatrist for a long time up in Northumberland, but had really got herself into a real mess. And duplex and CT showed popliteal stenosis and quite significant tibial disease as well. These were her initial angios, and this is in fact a colleague of mine who took her to angio first. You can see here behind the knee, behind this prosthesis, this lump of chalk. That's one of those sort of nasty sort of coralline bits of plaque. And here below the knee, there's no real named vessel running off into the foot. She does, however, have a really nice target in the foot. She went for just plain balloon. So this is the balloons. We did get through, my colleague did get through the anterior tibial lesion there and ballooned that all up to 2.5 mil. And that lasted about 5 days, and then everything recurred, unfortunately, and she got into even worse rest pain. So if you see, excuse me, these, this is the angio, and I took her to the theatre. She's still got this sort of plaque behind the knee prosthesis there on the picture on the right. And what you can see here is that she's actually taken out her AT completely now after it was opened up. So you can see the recipe down the left-hand side there. I managed to get a 3 mil spider filter into the dorsalis pedis of her foot, and then used the Hawk S device, which is their smallest, lowest profile device, and cut open the anterior tibial. And then actually with the same S device was able to attack that popliteal lesion, and then again drug coated the popliteal lesion and just used the standard plain balloon for the anterior tibial. So you can see that we've managed to debulk that lesion quite nicely and got the AT running as well. And the good news with her is that I actually just saw her Monday. And we've worked some real wonders. It's not just the atherectomy device, of course, it's multifactorial how we've got it to this point, but it's certainly helped giving her inline flow. It's a whistle-stop tour. I'm going to be completely honest. I think that atherectomy is, for the right patients, a bit of a game changer. I think it's great for neointimal hyperplasia. I think it's excellent for recurrent common femoral disease in those patients with where you're not desperately keen to go back into their groin. I think it's good for occlusive disease where you can avoid stenting. That's in both FemPop and in tibials. I think it's reasonable for calcified disease, but I think you need a lot of patience, especially with the Hawk device. And I think some of the other devices may be more effective in those horrible calcified diseases, as Ash has just shown. But again, recurrent common femoral disease, in-stent restenosis, occlusive disease, you get some really good results with it. So whistle stop tour through directional atherectomy. Happy to answer any questions. And guys, please stay safe. Thanks.
Many thanks, Craig. Just a quick question from me. What are the downsides of atherectomy? We work together and I'm quite convinced it does good in a lot of cases, but what are the downsides that you see?
I think that we've just got to, it's all about patient selection, isn't it? And I think that it's, one size doesn't fit all. I think I think it's this coralline, really resistant calcified disease. I still don't think we've got a better option than, certainly in the common femoral than an endarterectomy. So I think there is some limitations there. Obviously, with the Hawk device, it's limited in the very distal tibials because of the nose cone. And again, in the smaller tibials, again, it'll be limited in terms of its access. But I think one of its advantages is its versatility. So I think I wouldn't put it out of the question for anything really. The only area you can't use it in is in in-stent restenosis and Viabarn. Because if you pick up the fabric from the Viabarn, it's game over. Unfortunately, it'll close up like a purse string.
It's really handy. Thank you, Craig. We'll move quickly on to get Lorenzo's talk in. We've got about 15 minutes left, so Lorenzo, that's perfect timing for you, I think. So over to you.
Okay, thank you very much. So I've been invited today to talk about BTK segments, which is one of my favorite topics. And these are my 10 tips and tricks for BTK treatment. And actually, it's very important also nowadays to go online and to try to share our views and our experience with Zoom, like in this case. And I hope that even despite the evening, the night is quite late, you will still be here in the computer and enjoying my presentation. So these are my disclosures. And if you want to plan any kind of BTK intervention, which could be even the fanciest with the loop artery canalization, angioplasty, and great results, you always have to think about, first of all, at the level of the access. The access, which is usually an anterior access at the level of the common femoral artery, and this is exactly the door that you are knocking when you are going down. The common femoral artery needs to be punctured safely at the level of the femoral head, and it needs to be done definitely under ultrasound guidance. This will give us a lot of benefits like, for example, the accuracy of the puncture, not too close to the bifurcation, but not too high at the level of the inguinal ligament. If you use the ultrasound, you always have to find also the right spot where less calcifications are. So really, really mandatory. When the patients are a bit more challenging, like in this case with tissue loss and a little bit more overweight, there's the possibility that your sheath will end up very close to the common femoral artery bifurcation, like in this case where the sheath enter the profunda. And one of the tricks of succeeding in this intervention is know how to manage a difficult antegrade access. This is nice paper from my friend August Isa, who was online, and which shows this trick. You can cut the sheath like I did in this case, and you can see how I create a window with my scalpel, and through this window you can pass a catheter, and through the catheter you can have a wire. So while taking keeping the sheath at the level of the profunda, you can insert the wire and the catheter in the superficial femoral artery without risking to lose the access, which is so important in this kind of patients. Of course, if you are not able to do an antegrade access, also has been described the TAMI technique, so tibiopedal arterially minimally invasive retrograde vascularization, which just uses a very peripheral access like the dorsalis pedis or the posterior tibial artery to recanalize the vessels. Of course, when you recanalize the BTK, you need to know what is your target to obtain inline flow. And actually, sometimes it's very easy. You can see how in this patient, there's a short occlusion of the dorsalis pedis, or the anterior tibial artery going to the dorsalis pedis. And this was crossed successfully and dilated with a 3 millimeter angioplasty balloon. And I want to focus you on that data, 3 millimeter. Vessels are bigger than what we think. And this is a very nice paper which came out in March this year, which shows the diameter of vessels BTK. You can see the proximal anterior tibial artery and the proximal posterior tibial artery are over 3 millimeter of average size. So they are big vessels, never forget it. And the distal anterior tibial and distal posterior tibial have an average diameter of 3 millimeters. So don't underscore the possibility of using the right balloon for your angioplasty. Recalling is an issue, I will see it later. So, and in this case, you can see how the just angioplasty with the plain balloon resolves a lot of the problems. You can see the same frame rate, the same amount of contrast, and the blush at the level of the first toe, which was necrotic, which was not seen before. Of course, there's a nice paper which came out last month, foot angiosome extraction for use. It's a very nice, and I want you to read these little lines. High quality imaging of the leg on the foot vascular network to identify the relationship between the main arteries and their distribution. So our advice is to follow patient's anatomy and not book pictures. So why don't you read this paper, especially for the registrars and trainees who are online? Vascular imaging on the foot, published by Marco Manzi a few years ago. It's online for free on radiographics. It shows like you have to remember the two projections of the foot are definitely mandatory to understand better the anatomy, because we have seen that some images can be misinterpreted if you don't correctly take the two projections. So I want to show you this case, a guy who came with a foot attack. You see the necrosis at the level of the second toe with, of course, infection underneath. And the duplex was done in our center, showing anterior tibial and peroneal triphasic signal to the distal with the PTA, which just has a closer to 50% distal stenosis. So based on this duplex, assuming that the vascularization was good, the patient was amputated. But as you can see from this picture, the patient was not healing. And this was causing a lot of problems to him, and the possibility of the amputation to progress in a transmetatarsal amputation. So I insisted to put the patient on table. And you can see from the angiogram that what we are missing here, we're just missing the lateral plantar artery, which is the last artery from the posterior tibial artery, but where there's a good medial plantar artery and a good dorsalis pedis. But if you take the anteroposterior view of the foot, you can see in this picture, like the anterior tibial artery is providing almost no flow to the toes, giving just flow to the fifth. The posterior tibial artery is running here, then is divided in two branches. The medial plantar artery going to the first toe, and just a thread-like collateral is supplying the flow to what is our main artery for the toes, which are involved in the necrosis, the lateral plantar artery. And you can see here that all the branches, the second, the third, and the fourth toe are coming from this artery. So our target, and my target, was to try to recanalize, in this case of plantar dominance, the lateral plantar artery, which was occluded. And this is what I did. You can see here from my lateral view, the wire passing with a small loop into the distal lateral plantar artery. This was dilated with a 2 and then a 2.5 millimeter balloon. And from this result, we achieve a patency of this vessel again. But it's not only the lateral view, which is the most impressive, but it's the anterior posterior one. You can see how before it was occluded. And now with the artery patent, you can see a complete different blush at the level of the toes. But despite I'm a radiologist, I want to show you some pictures of the foot, because you can see how the foot progressed better and better after the revascularization. And I'm telling you, it was a foot which was going worse and worse. So this was actually very important till it completely healed to the perfect result. Remember, BT below the ankle treatment is crucial for this Rutherford 5 patients. I want to show you one more case. You see, this is a first toe which was necrotic, and the angioplasty at the level of the proximal anterior tibial artery was done by a 3x2 millimeter balloon by a colleague of mine. And actually, despite the better flow, the first toe was amputated, and the wound was not healing, was going worse and worse. You can see how the tissue loss was even far worse in the beginning. And I took the patient back, and I did, together with another angioplasty and stenting at the level of the origin of this vessel because it recoiled. Also, this angioplasty at the level of these 3 small occlusions on the very distal below the ankle vessels, dorsalis pedis and first metatarsal artery. Well, you can see from yourself, again, the same amount of contrast, same frame rate, and same velocity. You can see the difference in the flow, of course, in the velocity, and also in the blush at the level of the first toe. But again, it's very important not to focus on the single case, but on the literature. And also, for example, the rendezvous registry shows like patients who underwent to pedal artery angioplasty had a higher rate of wound healing and shorter time to wound healing. This was also confirmed by another meta-analysis done in 2019. And if you want to see the picture of the foot of this gentleman, you can see how it progressed very nicely. In few months, it completely healed. You can see how at the end, there was no any more tissue loss, and we saved this foot. Not only the angiographic or the real life picture, but I want to show you also the X-ray, and you can see how the osteomyelitis, which was one of the issues for this patient, completely solved. And now you can see the bone, which is very sclerotic, is a sign of good healing. Also, the pedal arch patency on tissue loss and time to healing is very important, as stated by these authors. So the pedal arch status has a positive impact on time to healing, limb salvage, and survival. This is one of the publications which are showing this. You can see that sometimes to navigate the foot arch can be simple. You can pass the wire very easily, and you can achieve a recanalization that you couldn't do before. Like you can see here, the contrast, which was coming out from a previous attempted antegrade attempt. And you can see how the vessel, which is restored, the posterior tibial artery, provides finally a very great flow to our zone of interest, which is of course, the calcaneal bone. And it's very important to notice also that it's not just the lateral view, as I said before. It's very much important to have an anteroposterior view of the foot guiding us. And you can see here how the foot arch always takes off at the level of the metatarsal bones between actually the first and the third one. So it's very important to have this kind of knowledge just to guide our guides and catheters. And you can see how I usually, when especially the arch is a bit tortuous, use this anteroposterior view of the foot. You can see how my wire is safely deployed through this tortuous anatomy. 014 wire, usually it's very good. For example, the commando 14. A case of foot arch recanalization, this patient came with another foot attack, and this was a guillotine amputation because of the very bad infection with gas in the subcutaneous tissues. And you can see how the wound was not healing at all, despite the amputation, and there was still a bit of infection and ischemia at the level of the sole of the foot. So this is just 2 images that should show you after the recanalization, also the anterior tibial artery, how the situation changes just with the recanalization of the foot arch. You can see in the pre and post, like again, with the same amount of contrast, like the blush at the level of the sole is very evident. And it's not just about the angiographic pictures, it's about also, of course, the foot, and you can see how the foot progressed and progressed, still completely healed. And I have to say that after 1.5 years from this intervention, the patient is still dancing, as she said on this newspaper. The last case I want to present to you is a 54-year-old man with scleroderma. He was an ex-heavy smoker, left leg below the knee amputation in 2013, just because of rest pain. And he was already listed for right leg below the knee amputation. So remember, he would have been a double amputee at 54-year-old just for rest pain, with both times no angiogram or lip salvage attempt. He's coming from far away, but he came to our center, and this was the first angiogram. It was just the peroneal artery reaching the foot. You can see how the vessels below the knee are not great. You can see just the lateral plantar artery. And remember, in these cases, intraluminal recanalization is highly preferable. I want to show other 2 different cases where the wire, and it's very important to stress the role of the CTO wires, it's passing through the calcium of this vessel and actually very easily goes through this occlusion in this other patient. Of course, the wire needs to be then exchanged to very much softer, not to risk the perforation of a safe vessel. And again, in this case, you can see how my CTO wire, which doesn't need to be pushed, just needs to be drilled. And this is valid for the BTK as for the SFA. the CTO wire are very good friends. You need to be very delicate without being brutal. You can see how the situation was crossed. So in this case, I tried the same, but unfortunately, I was not able to keep my wire intraluminally, and I extravasated. So what to do in this case? So I got an 035 wire, the same stiff Terumo with an 035 cutter, Navicross from Terumo again, and I was able to advance subintimally a little bit more. You can see the small injection of contrast, really 1 mil of contrast to check where I am. You can see some collaterals, but again, even using an 035 system, which is more safe usually not to extravasate, I extravasated anyway. So what to do in this case? So I took my ultrasound and I put the probe on the dorsalis pedis, which was completely occluded, but still very much seen on the screen. And I puncture and I try to pass a no-18 wire. You can see here how my wire tries to go through this occluded vessel. And I was lucky enough to pass my wire more or less through the same tract which I created antegradally. You can see my two wires, and you can see how my 018 wire is intraluminal here. And I reached the popliteal segment, I snare out the wire, and I was able then to put down a catheter, and you can see the dorsalis pedis is completely occluded. There's just a channel created by my catheter. I tried to recanalize the foot arch from this approach, but again, unfortunately, I was not very successful. It's a moment, it's a very bad moment after all this struggle, but remember, we never give up. We are CLI fighters, as many people in the US love to say. So I went for the posterior tibial artery, and you can see how my wire, and I'm glad that I also involved another colleague of mine, Professor Martimalina, who was with me, because I got, of course, a bit tired also of trying. It's very important to support your wire to create your space. It's something that he taught me. And you can see how the wire is going very, very gently. It's a real-time video. I'm not pushing a lot. I'm just trying to rotate it to try to create a space without extravasating. So actually, by doing this in a few minutes, actually, I was very close to the lateral plantar artery. This was the moment of the truth, and with my semi-stiff Terumo and my Navicross, I was able to cross into the lateral plantar artery. You can see how my wire goes into lateral plantar artery. When I injected, and it's something that you need always have to keep in mind, you can see like a very nice vascularization. It's just these vessels are freezed because I'm not getting any inflow. So I dilated everything again with a 3 millimeter balloon at the level of the ankle level, which is the right size balloon. You can see my result was good. And I decided also to try to recanalize the foot arch, which was almost complete. And you can see my commando 14, which is going through this occlusion and finally re-entering into the anterior tibial artery. By dilating the whole foot arch, and of course the anterior tibial artery, again, even distally with a 3 millimeter balloon, I got this very nice result. So with free vessel runoff to the foot, and you can see how finally there's the patency of the foot arch. In this case, also dilated a little bit more the dorsalis pedis, which was stenotic, still at this level, and posterior tibial artery. And then I thought that I won my battle. And always, in this case, especially when it's very complicated, you know how recoiling is an issue. It was described by Baumann in 2014. So elastic recoil was observed in 97% with a mean luminal compromise of 30%. And you can tell yourself how it's important, especially in BTK vessels, to reconsider that. So always check at 15 minutes. Vessel recoil is an issue, as I said, and you check and you notice that after 15 minutes, the vessel doesn't look good as good as before. You can see this small, very tight stenosis. And again, at the level of the distal reentry, you can see how the posterior tibial artery has a recoiling at this level. So this was angioplasty again by a shorter balloon, so 3x4. Remember, always start with long balloons that go shorter for more aggressive treatment. And the lesion at the level of the mid posterior tibial artery required a stent. And this is the stent which I positioned there. Consider stenting for short to medium length lesions. It's a mantra. So remember, there's level 1A evidence which supports the use of infra-popliteal drug-eluting stents for short to medium lesions. And the final result was quite good. You can see how the flow to the foot is coming together. So anterior tibial artery and posterior tibial artery are coming together with no flow slowed in one of the two vessels. And if the people don't believe that these are good results, which can also keep the patency of these vessels for a long time, I want to show you some texts from this gentleman who actually very kindly agreed to show his texts. He says in November, after 1 month from the intervention, he says there's a very good pulse in his foot. And actually in December, he says that my foot been warm, forgot what it felt like. Thank you very much. And I recorded this interview just a few days ago, and I will let him speak.
And it's fine. And before you were not able to sleep in this position, am I right? No, I hate that. Okay. You hung the leg over the bed, get to sleep.
So I don't know if you heard that, but he says that he can walk now every day without any pain, and he's not has no any more rest pain where before he was not able to sleep. So this is my presentation. I finished with my 10 secrets. I tried to run a little bit because the time was a bit short, and I'm glad there are no secrets between me and you. So I thank you for your attention, and I wish you good luck for your interventions in the near future.
Lorenzo, thanks so much. It's a brilliant talk and some really inspiring cases there, I think. We have actually reached our time. We're nearly bang on time, but we don't have time for any more questions. And so I'm going to call this session to a close. Just time to thank the panelists, Murray, Craig, Ash and Lorenzo, thanks very much. And the organising committees from both the Vascular Society and BSET for helping host this. Thank you, everybody, and good night.
Thank you very much. Bye.
Good night.